Hi, I am so delighted to meet you in the program of JIP's Horse and Heart News. Yesterday, 21-year-old male presented with hyperglycemia, sugar level, postprandial sugar level around 451, but he doesn't have any symptoms and signs of ketoacidosis. Then we inquired about his history of diabetes. He was detected to have diabetes 2 years before. Concerning his high sugar value, when it was detected, sugar value was around 600. So he was started on short-acting insulin and long-acting insulin. Basal bolus regimen has been started for him. Then he discontinued his treatment. Then he presented with 450 milligram of sugar. When we extracted detailed history, then we realized that he didn't undergo any autoantibody test to rule out type 1 diabetes for him. Then after getting consent from him, then we did autoantibody test to rule out type 1 diabetes. So we did all the autoantibodies including antibodies against insulin, then antibodies against islet cell, then antibodies against GAD65, then antibodies against zinc transport protein 8. So out of this, he was turned out to be antibodies against GAD65. So when somebody presents with high sugar, especially less than 30 to 35 years, so it is paramount to rule out type 1 diabetes. The reason would be, if patient is found to have type 1 diabetes, rather than taking trial with oral hypoglycemic drugs, then we will make the patient understand that he should be on insulin forever. So after doing all these autoantibodies, out of 4 autoantibodies, he turned out to be GAD65 positive. So the purpose of doing autoantibodies in any patient presents with hyperglycemia below 30 or 35 years is to rule out type 1 diabetes. Then apart from that, when you do these autoantibodies in the first degree relative of those who have had type 1 diabetes, and when they turned out to be positive for any one of the autoantibodies, then it has been learned that these people, even though they are not presenting with hyperglycemia, even though they present at normal hypoglycemia, but when they turned out to be positive for autoantibodies, it indicates that there will be development of type 1 diabetes almost 45% in 5 years. That we have to understand. So the purpose of doing autoantibodies in suspected type 1 diabetes is to prove the diagnosis. The purpose of doing autoantibodies in normoglycemic relative of those who have type 1 diabetes is whether they may develop type 1 diabetes in near future or not. So any patient who presents with hyperglycemia less than 30 to 35 years, better to do autoantibodies to rule out type 1 diabetes. Then if autoantibodies are negative, then probably another 2 important diagnoses, either a monogenic diabetes or MODY or type 2 diabetes. If they have type 2 diabetes, the features of type 2 diabetes in less than 30 years, family history of diabetes, 1, and second one, they will have higher BMI value and they may have markers of insulin resistance including acanthosis nigricans. So if they don't have features of high BMI, then no features of acanthosis nigricans, or no features of metabolic syndrome, or if somebody presents with hyperglycemia without any features of type 2 diabetes mellitus, without detection of autoantibodies, then probably you may be forced to think of MODY. Then monogenic diabetes, you have two types. One is neonatal diabetes, commonly seen in less than 6 months of old baby. Then another one is MODY. The MODY features of MODY, they will have borderline hyperglycemia. They won't have positive autoantibodies. They won't have features of or markers of type 2 diabetes. So they will have borderline hyperglycemia. HbA1c may be less than 8%. They will have history of diabetes in first degree relative, and if you do C-peptide, if C-peptide is less than 200 picogram per liter, automatically then it is type 1 diabetes. Then if you have C-peptide more than 200 picogram, then when you say all these features of MODY, then probably patients should be subjected to genetic studies for confirming the diagnosis of MODY. Otherwise, sometimes subtypes of MODY, they may have renal cyst and partial lipodystrophy. These are some of the features of MODY. So this is the way you have to approach when somebody presents with hyperglycemia less than 30 years. And sometimes with very classical presentation, type 1 diabetes patient may present with diabetic ketoacidosis symptom. Type 2 diabetes patient, they may have classical features of high BMI, family history of diabetes, acanthosis nigricans. When you have difficulty in evaluating or differentiating the types of diabetes, then probably you may follow this approach. Then Indian setup, we have fibrocalculus chronic calcific pancreatitis. That's one entity also to be remembered. You just do X-ray abdomen or USD abdomen, that may show many features of calcification in the pancreas, signaling chronic calcific pancreatitis. Then one more patient, 3 days before, we received with the complaints of severe giddiness, 55 years old male with history of algal consumption for more than 3 decades, admitted with severe giddiness. His CBG was showing 457 milligram per DL. Then we did HbA1c, that showed only 4.7%. So my medical officers got confused. Then routine investigation revealed that his urea was 122 and his creatinine is 1.1. Few days before, I told the differential diagnosis for isolated elevation of urea or disproportionate elevation of urea and normal creatinine include upper GI bleed and dehydration or prerenal azotemia, and third one, those who are taking prolonged corticosteroid therapy. So this patient, when he presented with sugar level of around 457 with urea around 120, then when we inquired the history, he had abdominal pain. Then routine examination revealed he was paler, his hemoglobin was only 6 gram. Then we realized that there is some amount of blood loss must be there, because he has anemia, abdominal pain and elevated urea and normal creatinine, signaling towards upper GI bleed. When we scrutinized his history in detail, he revealed that he had melena. So finally we concluded that he had upper GI bleed secondary to chronic liver disease thanks to chronic algal consumption, resulting in falsely low HbA1c value. That's why even though he presented with sugar level of around 457, but his HbA1c is only 4.7, the reason would be one of the reason for falsely low HbA1c in the presence of high sugar is acute blood loss. Apart from hemolytic anemia, one of the reason for falsely low HbA1c value is acute blood loss. So this patient finally underwent upper GI endoscopy and we found out esophageal varices, for which banding was done. Now he was doing well. So this case was projected to highlight one of the cause for falsely low HbA1c is hemolytic anemia and acute blood loss. And one more patient presented with exertional dyspnea, mild pedal edema and elevated JVP, suspected to have congestive heart failure. I couldn't make out frank S3, basal cryptations there was not marked one. Then he was subjected to echo that showed ejection fraction of around 36% with regional valve motion abnormality signaling coronary artery disease. So what are the drugs that can enhance our LV function? You can remember one code word, that is SAC. SAC means SAC, we are all aware of that. You have to remember here SAC, SACC. So what is S? SGLT2 inhibitor. So it has been proved with multiple studies that SGLT inhibitor, especially EMPA and DAPA, can improve LV function. So any patient who presents with ejection fraction around 35% or 40% with lower ejection fraction, we should always strive to introduce SGLT inhibitor, especially DAPA. The only contraindications for DAPA is if GFR is below 25 ml per minute, or if patient has lower BP, like BP is around 90, you should be very cautious. Then among the SAC, another one is A, that is aldosterone antagonist. So here we are using aldosterone antagonist is aldactone, that stands for A. So when you use aldosterone antagonist on long term basis, it has been found that it will improve your LV function. The main important contraindication for introducing aldosterone antagonist is hyperkalemia. So if potassium level is more than 4.8 milliequivalent per liter, then you should refrain from administering aldosterone antagonist. Then another C is carvedilol, so beta blocker. You just introduce beta blocker 3.125 milligram morning off and night off, but you should take always a note on active heart failure and blood pressure. When you have active heart failure with prominent cryptation all over the chest, then don't introduce carvedilol hastily. You introduce carvedilol with lower dose when patient has good amount of blood pressure, at least 100 mmHg with dry lung. Then last one is C. C for Sidmas. Even though it is a brand name, to memorize this mnemonic, I want to use it. You just use Arni. So what is the contraindication for Arni? is elevated urea creatinine. If you have elevated urea creatinine, gradually introduce ARNI. So all these 4 drugs, SAC, SGLT2 inhibitor, aldosterone antagonist, carvedilol beta blocker and SIDMAS or ARNI will be useful in enhancing your LV function. Thank you.